Very good evening, everyone. I welcome you all to the yet another revision session and high yielding points for the upcoming FMGE exam. Today is 9 of December. We have 2 more days for the exam. I hope all you guys are preparing well, revising well. So this session is going to be a revision session with the high yielding points. I'm sure this revision session is going to help you. This crucial time, all you guys must be reading all the books, keeping all the books near to you, reading everything, try to thinking that you are forgetting something, reading. Please don't get anxious. Just relax and revise well. Try to start one-liners from tomorrow. Do only one-liners tomorrow and day after tomorrow. And all the very best for everyone who are appearing for the exam. I hope all you guys clear the FMGE exam and get your registration in the concerned medical council and start your PG preparation soon. So yes, we will start. Today we'll be discussing all the subjects. In all the subjects, high yielding points, the questions that were asked previously in NEET and in FMGE. And let's start. In blood transfusion, we have certain questions that has been asked in NEET and in FMGE, which were not much covered by us. So in blood transfusion, we use certain preservatives. These preservatives are very important as this has been asked in FMGE exam. Preservatives are usually citrate based. In blood transfusion, we use the citrate used is trisodium citrate. It is an anticoagulant. So we are using citrate. You must have learned in glycolysis about the citrate. How this trisodium citrate acts as anticoagulant is it chelates the calcium present. And the first preservative we are going to discuss is ACD, acid citrate dextrose. This is a short topic. If you're feeling like you're learning this newly, surely it's going to help you. Please learn this. Just it's going to take 5 to 10 minutes only. Just you have to know the name of the preservative and the limitation and the advantages as this has been asked. Acid citrate, it is an anticoagulant. Dextrose gives nutrition to the RBC. Shelf life of ACD blood is going to be 21 days. Limitation is it has low 2,3 dpg. You must have learned it in biochemistry, physiology. Low D, 2,3 dpg means there will be low oxygen delivery. And next, ACD with the phosphate. It's citrate, phosphate, dextrose, Because of the phosphate added, it increases the 2,3 DPG, so increased oxygen delivery. This is CPD, citrate phosphodextrose with CPD. Then they added adenine to it. This is CPDA. The CPDA has adenine. This adenine increases the red blood cells ATP has adenine triphosphate, so it increases the red cells ATP, so it's going to increase the shelf life. Previously we saw the ACD shelf life is 21 days. Here, because of the addition of adenine, it's going to increase the shelf life to about 35 days. And the last one is CPDSAGM. With the CPV, they have added saline, adenine, increases the ATP. Also, they added glucose and mannitol. Both these are osmotic, so it decreases the cell swelling, thereby decreases the lysis or breakdown of RBC, and because of this, the shelf life is going to increase to 42 days. And this is the most commonly used preservative, CPDSAGA. Not GA, SAGM. Sorry, SAGM. This is with the preservatives. Then we coming to the carcinogens. Carcinogen can be a protogen oncogene mutation. It can be because of a tumor suppressor gene alteration or mutation, DNA repair defects, inhibition of apoptosis, and also because of excess action of certain growth factors like hepatocellular growth factor for HCC, insulin-like growth factor 2 for Wilms tumor, VGF for glioma, can be because of a growth factor receptor mutation, HER2 new. Yes, can anyone tell me? HER2 new mutation leads to what cancer? Please text in the chat box. EGFR, lung cancer, most commonly the adenotype, adenocarcinoma, ALK1, ALCL mutation is seen with adenocarcinoma of lung. Yes, very good. Naveen, breast cancer is correct answer. Breast cancer is seen with the mutation of HER2 new. c-KIT mutation is seen with gastrointestinal stromal tumor, GAST, also with seminoma. Yes, Sambat Jojo, correct. Breast cancer is correct. And we go for nuclear regulatory proteins. Because of the alteration of nuclear regulatory proteins, it can end up in a cancer like CMYC, Burkitt's lymphoma, and CA colon. NMYC, N for neuroblastoma, LMYC, L for lung cancer, mainly the small cell variant of lung cancer. Tumor can be because of a signal transducing protein mutation or alteration like tyrosine kinase. Yes, tyrosine kinase altered in which cancer? That's a question for you guys. ROS, colon cancer, pancreatic cancer, thyroid, lung, and this ROS is the most common proto-oncogene mutation. Whereas the most common mutation overall is P53. Yes, tyrosine kinase pathology, CML, tyrosine kinase. We move on to glycogen storage diseases. The name of the enzyme that are deficient has been asked in the exam. Disease and the enzyme deficient. Von Giarkis, glucose 6 phosphatase, Pompe's disease, acid maltase, Cory's debranching enzyme, C, D, and Anderson's, it is the branching enzyme. You can remember with A, B, and C, D. In McArdle's disease, the enzyme deficient is muscle phosphorylase, M for M, and in Hirsch's disease, the enzyme deficient is liver phosphorylase. This is with glycogen storage diseases. Von GRK and McArdle's has been frequently asked in the exam. They just asked the name of the deficient enzyme, and that's it. It's gonna get you a 1 mark. So please remember. Is Jiva correct? Von GRK's disease, G6P, glucose 6 phosphatase is deficient. Then we move on to few rate limiting enzymes. Rate limiting enzymes has been asked in every exam, I guess. So rate limiting enzymes are very important in your morning session biochemistry. Pathway rate limiting enzyme. Glycolysis, the rate limiting enzyme is phosphofructokinase 1, PFK1, Krebs cycle. Please tell me in the chat box, what is the rate limiting step of Krebs cycle? Gluconeogenesis. Rate limiting step is fructose 1,6 bis phosphatase. Glycogenolysis. Rate limiting step is glycogen phosphorylase. Yes, very good. Ashley Simon, isocitrate dehydrogenase is the correct answer. Very good. HMP shunt, the rate limiting step is G6PD glucose 6 phosphate dehydrogenase and this has been asked in the exam. Very simple question they had asked. They have given us what is G6PD? This is the question. What is G6PD? And the options were they were given like glucose 6 phosphate dehydrogenase, glucose 6 phosphate dihydrogenase, glucose 6 phosphate decarboxylase. They have given question like that. So they just asked the abbreviation of G6PD. So this is important. They can ask you like with any type in this rate limiting steps. Then in protein metabolism, we have urea cycle, and the rate limiting step is CPS1 or carbamyl phosphate synthase 1. In lipid metabolism, we have beta oxidation of fatty acid, and the rate limiting step is carnitine acyl transferase. Shubham Chaudhary, sir, PSMB Karogi. Sorry, I don't understand Hindi. Please test in English. Ornithyl acyl transferase. Ketogenesis. Rate limiting step is HMG CoA synthase. My question is HMG CoA reductase is the rate limiting step of which pathway? Purine synthesis. Yes, we will cover all subjects, important questions of all subjects. Purine synthesis, PRPP, glutamyl amido transferase. I guess in this rate limiting step, sure one question will be coming. Sure, 1 mark is there for you guys if you learn only this chart. You will learn some amino acids and special products. Very good, Ashley Simon. Very, very good. Cholesterol synthesis and pharmacology. What drug inhibits HMG CoA reductase? Yes. Answer please, Ashley Simon or anyone present. What is the drug that inhibits HMG CoA reductase? Very good, Sampath Jojo. Statins inhibit. Correct, Ashley Simon and Sambat Jojo. The answer is statins. HMG-CoA reductase is the rate limiting step for cholesterol synthesis, whereas HMG-CoA synthase is the rate limiting step for ketogenesis. Pyrosin gives melanin inside the melanosome, T3, T4 in the thyroid gland, and catecholamines in the adrenals. Tryptophan gives rise to melatonin, serotonin, and niacin, vitamin B3. Remember the other name 5-hydroxy tryptamine and not tryptophan. Histidine gives histamine, and arginine gives nitric oxide. This also has been asked in the exam multiple times. Arginine gives nitric oxide. Few inhibitors. Inhibitors also has been asked in the exam. Fluoride inhibits enolase in glycolysis. Barbiturates and protanone inhibits the complex one of the electron transport chain. Malonate inhibits complex 2 of the electron transport chain. Carbon monoxide, hydrogen sulfide inhibits the complex 4. Oligomycin inhibits complex 5 of ETC. Few points about the cofactors. Coenzymes are vitamins, whereas cofactors are minerals. Cobalt, constituent of the vitamin B12. Vitamin B12 is the cobalamin or cyanocobalamin. Chromium, potentiate the action of insulin. Fluoride is present in bone and teeth. Iodine is important for thyroid hormone synthesis. Molybdenum is a cofactor for which enzyme? Please tell me in the chat box. Molybdenum has been asked in the exam. Selenium is the cofactor for glutathione peroxidase. Zinc, cofactor for carbonic anhydrase. Alcohol dehydrogenase. Manganese is the cofactor for, yes, Ashley Simon, very good. Xanthine oxidase. Like, can you tell me the inhibitor of xanthine oxidase? What is the name of xanthine oxidase inhibitor and where is it used? Is pharmacology. Manganese is the cofactor for arginase and enolase. Very good. Ashley Simon. This inhibited by the allopurinol and it is used in gout. Is the correct answer. And this has been asked in the exam. Xanthine oxidase inhibitor is allopurinol. Pharmacology. Then we'll move on to some immunohistochemistry markers associated with tumors. IHC marker and the associated tumor. Vimentin, Tesmin associated with mesenchymal tumors and sarcomas. Cytokeratin is a marker for carcinoma. Calretin, mesothelin, marker for mesothelioma. Chromogranin, synaptophysin, neuron specific enolase are all markers of which tumor? Yes, 100 melanoma and also for neuroendocrine tumor. HMV 45 It's a marker for melanoma. CD1A, Langerhans cell histiocytosis. What is the name of the granules seen with Langerhans cell histiocytosis? It is a pathognomonic sign for Langerhans. If that granules is seen in the blood smear, it's going to be Langerhans cell histiocytosis. CD117 is the marker for GAST, gastrointestinal stromal tumor. Very good, Sampath Jojo. Birbeck granules. And what is that appearance seen with Birbeck granules? Very good. Very good, Sampath. Tennis. Hackett appearance. Seen with Langerhans cell histiocytosis. CD117, GIST, GAST, gastrointestinal stromal tumor. CD99, yes, Ashley Simon, correct, tennis racket appearance. CD99, Ewing's sarcoma. Thyroglobulin is the marker for thyroid carcinoma. Progesterone and the estrogen receptors are the marker for breast carcinoma. PSA are the prostate specific antigen is the marker for prostate cancer. Placental alkaline phosphatase is the marker for germ cell tumor. Inhibin is the marker for, yes, inhibin is the marker for WT1, marker for Wilms tumor. So this is IHC markers, immunohistochemistry markers. Very, very important, guys. So chromogranin, synaptophysin is a marker for neuroendocrine tumors. Langerhans cells histiocytosis is important, has been asked in the exam. Inhibin, yes, inhibin. Okay, correct, Sampath Jojo. What about inhibin? Inhibin is the marker for granulosa cell tumor. No, not ovarian cancer. Okay, but be specific. It is granulosa cell tumor. Next, we'll move on to some important pathological bodies. Inclusion bodies and the disease. LD bodies or the Leishman Donovan bodies. Yes. Which one? Which disease? Leventhal Coles little bodies seen with psittacosis caused by chlamydia. Lewy bodies seen with Parkinsonism. Neurofibrillary tangles are seen in which disease? And this has been asked in previous FMG exam. Neurofibrillary tangles are seen in. LD bodies are seen in. Neurofibrillary tangles are seen in. Please answer in the chat box. Mallory bodies seen in primary biliary cirrhosis. Sambat Jojo, correct. Neurofibrillary tangles are seen in the Alzheimer's disease, correct? And also Hirano bodies are seen with the same Alzheimer's disease. LD bodies are seen in Kala Azar, black disease. Mallory bodies are also seen in alcoholic cirrhosis, hepatitis. Yes, correct. Sambat Jojo. LD bodies are seen in Kala Azar. Correct, Akash Babu. Kala Azar, black fever. In Wilson's disease. And also in HCC. Michaelis Batman bodies are seen in Malakoplikia. Miyagawa bodies or corpuscles seen with LGV, lymphogranuloma venerum, Aulai inclusions are seen in which disease? Aulai appearance seen in which cancer of thyroid? Which type of thyroid cancer? This Aulai inclusions are seen in and the Aulai appearance is seen. Next, thick bodies are seen with Hicks disease. Yes, correct. Karishma. CMV is the correct answer. Cytomegalovirus is the correct answer. Aulai inclusions are seen with CMV. Aulai appearance, Sambat Jojo, Karishma, correct. Papillary cancer of thyroid, and it is the most common cancer of thyroid. Yes, Aulai inclusions, Reed-Sternberg cells are seen in Hodgkin's lymphoma, correct. Samoma bodies are seen in papillary cancer, thyroid. Serous cystadenoma of ovary. In meningioma. Mesothelioma. Rokitansky bodies are seen in teratoma. Russell bodies seen multiple myeloma. Shaman bodies are seen with sarcoidosis. Yes, correct. Karishma Nagakumar, orphan Annie appearance is correct. Common bodies are seen in sarcoidosis. Schiller dual bodies are seen in, please. Tell me, Schiller dual bodies, sclerotic bodies seen in chromoblastomycosis, Sambat Jojo, Schiller dual bodies, please rethink again. Correct, Ashley Simon. Schiller dual bodies are seen in yolk sac tumor. Correct, Karishma, YCT, yolk sac tumor, YST. Sclerotic bodies are seen in chromoblastomycosis. Torus body are seen in yellow fever. Verroque bodies seen in schwannoma. And, yes, Priyanka Maharajan, correct. Torus bodies are seen in yellow fever. Zebra bodies are seen in metachromatic leukodystrophy. Yes, Priyanka, correct. Verroque bodies are seen with schwannoma. Next, we'll move on to some genetic disorders by chromosomes. We completed everything, I think. Yes. Yeah. Owl appearance, orphan anenuclei, papillary cancer of thyroid has been asked in the exam. Some genetic disorders and their chromosome number involved. Chromosome disease. We have something called von Hippel-Lindau disease. Which chromosome? Same chromosome for RCC, renal cell carcinoma, which is the number of the chromosome. Chromosome 4 for AD PKD or the PKD2 adult type, autosomal dominant. 5 Cleidochat syndrome. And also the FAP, very important chromosome number for FAP. Familial, very good, Ashley Simon, correct. Chromosome number 3, this is also important. And the chromosome number for FAP is number 5, it's also very important. Familial adenomatous polyposis. Chromosome number 6 is for hemochromatosis. Number 7 Williams syndrome. Now we have two types, PKD1 and PKD2. PKD1 chromosome 16 and the PKD2 is chromosome number 4. Please recheck your notes. ADPKD or PKD1 is 16, whereas the PKD2 ADPKD is chromosome number 4. Seven Williams syndrome and cystic fibrosis. Chromosome number 9, tuberous sclerosis, TSC 1, yes, Karishma, chromosome number 7, cystic fibrosis, Wilms tumor, chromosome number 11, Wilms tumor, 13, what is the syndrome? 13, previously asked in the FMGE exam, chromosome number 13. Wilson's disease is also chromosome 13, but my question is, which is the syndrome associated with chromosome 13? Retinoblastoma also involves the chromosome number 13. Very good, Karishma. Patau syndrome. Retinoblastoma, correct, 13. Prader-Willi syndrome, Angelman syndrome, 16, BKD 1, and tuberous sclerosis, TSC 2, 17, neurofibromatosis type 1, BRCAI, 18, yes, 18, which syndrome? 21, which syndrome? 22 is neurofibromatosis type 2. Type 1 is 17. This is with chromosomes. Edward is which one? 18. Correct. Correct. Sampat, Jojo, Karishma. 18. Edward syndrome. 21. Digeorge, Downs. Okay. 22q11. Okay. Yes. 21 is Down syndrome. This 18, 21, and 13 has been asked in the exam, and they can confuse you by giving the same Patau, Edwards, Downs for the chromosome as we get confused. So you can remember with mnemonic. Puberty age is usually 13. Election age is usually 18. Drinking age is 21. D for D, E for E, and P for puberty Patau. Can remember like this. So we will move on. Some important one-liners about ATT. Please get thorough with ATT drugs pharmacology. Very important. What is the ATT drug that is associated with peripheral neuropathy? What's the drug? Associated with psychosis is isoniazid. With associated with transient memory loss Yes, we are going to cover high yield important points that to be remembered that has been asked in the previous exams and possible question for the upcoming exam. Is Sumit Deda correct? No, my question is associated with peripheral neuropathy. Isoniazid is correct. Transient memory loss is the same isoniazid. What is the ATT associated with? Hyperuricemia. Peripheral neuropathy is not with ethambutol. Peripheral neuropathy is with isoniazid. I think we have learned it one day ago in the live session. Isoniazid inhibits absorption of which vitamin? Vitamin B6. Vitamin B6 is important for the strength of the nerve, and when there is decrease in vitamin B6, is going to end up in a neuropathy. Isoniazid inhibits the absorption of vitamin B6, so it's going to cause a peripheral neuropathy. Not ethambutol, Sumit Dida. Hyperuricemia, which one? Very good. Sarika Pillai, very good. Hyperuricemia is seen with pyrazinamide. Orange. Discoloration of urine. Rifampicin. Contact lens. Staining. Again, rifampicin. Correct, Sarika Pillai. The orange discoloration of urine is seen with rifampicin. Retrobulbar neuritis is caused by ethambutol. Safest in renal failure is again rifampicin. Least toxic drug is again rifampicin. ATT that is contraindicated in pregnancy is streptomycin. ATT that is best for a rapid grower or a rapid correct saricapillary streptomycin, best for rapidly growing bacteria is isoniazid. Maximum CSF penetration is seen with isoniazid. Best for bacteria in caseous necrosis is rifampicin. So this is with ATT. Let's move on to some points about bacterial endocarditis, most common causes. Native valve endocarditis. Overall, hospital acquired most common causes. Very good, Ashley Simon. Very, very good. Staff for yes. Native valve endocarditis. Community acquired. Yes, Ashley Simon. Community acquired is strep viridans. Early prosthetic valve endocarditis, that is less than 12 months, is staph epidermidis, whereas late prosthetic valve endocarditis more than is native valve endocarditis. Community acquired is caused by strep viridans. Late prosthetic valve endocarditis is also caused by strep viridans. Yes, Sarika Pillai. Strep viridans is the most common cause of native valve endocarditis, community acquired, and the most common cause for late prostatic valve endocarditis, more than 12 months. If they ask overall prostatic valve endocarditis, most common cause is going to be again epidermidis. Epidermidis is the overall cause for prostatic valve endocarditis. Endocarditis is in IV drug users or abuses. Right-sided is caused by left-sided, right-sided by staph aureus. Left-sided, correct, Sarika Pillai, staph aureus. Right-sided, and left-sided is by enterococci, then staph aureus. And the overall is again staph aureus. Endocarditis and IV drug abusers. Overall is again staph aureus. Subacute. Yes, correct. Ashley Simon, left enterococci. Subacute infective endocarditis is caused by Paglase negative staphylococci, also by Streptococcus viridans and ASEC organisms. Culture negative endocarditis is caused by Coxiella burnetii, Bartonella, ASEC organisms. This is with the most common in endocarditis, bacterial endocarditis. Next, we move on to some arthropod-borne diseases. Vector diseases. Louse is the vector for PERT. Very important. Please remember, Louse is the vector for pediculosis, epidemic, typhus, relapsing fever, and trench fever. Flea is the vector for which diseases? Cyclops, the vector for Guinea worm disease, and for T. latum, yes, Karishma, endemic. What endemic? Yes, correct. Flea is a vector for plague, bubonic plague. Also for the endemic typhus, black fly as a vector for onchocerciasis, red weight bug, Chagas disease, CC fly, the one that causes sleeping sickness, African sleeping sickness. This is some important. Here the louse question has been asked. Please remember PERT, pediculosis, epidemic typhus, collapsing fever, French fever. Whereas the endemic typhus is caused by flea. Next, we'll see about some agent causing occupational carcinomas. Arsenic causes skin cancer, lung cancer, and liver HCC. My question is, asbestos causes what cancer? Benzene causes leukemia. Aniline dyes causes urinary bladder cancer. Chromium causes cancer of nasal sinus and lung. Yes, asbestos causes, very important, mesothelioma. In PSM, we have waterborne diseases classification, and this has been asked in the exam. So I want to cover this, very important. Asbestos causes mesothelioma. It is a type of, is lung cancer is correct, but what lung cancer? It is mesothelioma. They're not going to give you the option as lung cancer. They will give you specifically. They will ask you. So mesothelioma. Waterborne diseases classification is seen very important in PSM, SPM. So you see classification, mode of disease, and the examples. Waterborne disease are spread via the fecal-oral route. Examples: typhoid, cholera, dysentery, viral hepatitis A. When we have water-washed disease, water-washed disease mode is going to be because of the improper hygiene or inadequate water use. Remember that there is no proper water wash of the body. So it's because of water washing, lack of water washing, and the disease caused are scabies, trachoma, typhus, water-based disease caused by aquatic invertebrate animal. Diseases: schistosomiasis, dracunculosis, and the water-related disease or water-breeding disease is caused by the insects. They are depending on the water. They are disease like malaria, filariasis, dengue, yellow fever, all those insect-borne diseases. This is with water-borne diseases, water-washed, water-based, water-related diseases. This is the classification. This has been asked in exam. Next important is SCG levels in different conditions. In increased HCG, decreased HCG. If there is multiple fetus, increase HCG. In molar pregnancy, increased. Down syndrome, increased choreo. Can somebody tell me what is the drug of choice for choriocarcinoma? Increased HCG is seen in choriocarcinoma, whereas decreased HCG is seen with the failed pregnancy. In ectopic pregnancy, in case of impending spontaneous abortion. Yes, very good, Sampath. Jojo, the drug of choice is MTX or the methotrexate. What is the mechanism of action, or either what is the vitamin that is being blocked by this methotrexate? What is the name of that vitamin? It inhibits vitamin B9. Vitamins are very, very important, friends. Surely we'll get a question, 4 to 5 questions. Correct, Manjeet Sharma, vitamin B9. Next, we'll move on to folic acid, correct. Important radiological scoring by rats, breast imaging, reporting and data system. Pirates is very, very important. We have category and how we are going to manage it, and what is the chance of developing a cancer. Likelihood of cancer. Category 0 needs additional imaging or examination. This BIRADS is done for breast cancer. So 0 category, it needs additional imaging, maybe like a MRI or a mammography, and also general examination of the breast. Management is to wait for the additional imaging and look for it. Likelihood of cancer is not available, and it's only available when we go for additional imaging or Fourier examination. Category 1 is considered as negative. Essentially 0% for developing cancer. Management is go for routine screening. Category 2 is benign. Routine screening is the management. Like if, for example, we have adenoma of the breast. It is essentially 0% chance for developing cancer. Category 3 is probably benign. The management is short interval follow-up and wait for any growth or change to malignancy, like 6-month period, every 6 months, or we can also follow up continuously. Chance of developing is more than 0%, but less than 2% for developing cancer. This is 3. And we have category 4. There is some suspiciousness whether it is cancer. We go for pathological tissue diagnosis. And in 4 category, we have 4A, which is low suspicious for malignancy, and the risk is more than 2% to less than or equal to 10%. 4B is moderate suspicious, more than 10% to less than 50%. 4C is high suspicious for malignancy, and the risk is more than 50% to less than 95%. Category 5 is highly suggestive of malignancy. Management is going to be, next step is going to be tissue diagnosis, and that is chance for more than 95% malignant. And 6 is category 6 is known biopsy proven. We have took a tissue diagnosis and the biopsy shows malignant cells, microcalcifications. There's going to be a malignant lesion, and the management is going to be surgical excision. And it is already proven. This is PIRATs. They have asked in this past FMGEs exam. Please know this classification of screening for breast cancer. Next, we'll go for some named fracture classifications. The fracture classifications have also been asked in the exam. Name fracture. Allman's classification is for fracture clavicle, most common fracture overall. Mears classification is for fracture proximal humerus. Gotland classification is for supracondylar humerus. Rados classification is for Montegia fracture. Tiles classification, fracture pelvis, Judet and lectornal classification for fracture acetabulum. Hopkins is important, has been asked. Hopkins classifications for head of femur fracture. Gordon or Powell classification for fracture neck of femur. Quinquist and Hansen classification is for fracture shaft of femur. Essex Lopresti is also important. Essex Lopresti is for fracture calcaneum. Steenberg classification is also important for avascular necrosis. This is some named classification for specific fractures, very important. Next, we will move on to very important topic in SPM, STD color coded kits. Very important topic, guys. STD color coded kits. Clinical condition. What is the color of the kit to be prescribed and what are the drugs included? They can give you the clinical condition and they can ask you the color, which color you used, or they can give you an image of the color kit and they can ask you what are the drugs that are present in that kit. So very important, clinical condition and the kit. If the complaint is urethral or anorectal or cervical discharge, color is going to be gray and the kit number is kit 1, gray color, and the drugs included are azithromycin and cefixime. This is kit 1. If there is complaint of vaginal discharge or vaginitis, kit 2 should be given and the kit 2 color is green in color. The drugs included are signidazzole and fluconazole. Yes, anyone can tell me what's the color of kit 3? There is complaint of genital ulcer and the ulcer is non-herpetic. Kit 3. Kit 2 is green. Already we saw kit 2. Kit 3, what's the color? It is white. And the drugs are correct, Kamal. White is the color for kit 3. Drugs included are azithromycin, if there is a genital ulcer, it is non-herpetic but the patient is allergic to penicillin. Then we give kit 4, blue in color, and it includes doxycycline. What's the color of kit 5? Genital ulcer disease, which is herpetic. We are going to give kit 5, and what is the color? And the drug is going to be herpes. So acyclovir is going to be the drug of choice. Yes, correct. Kamal Kirolia, I think correct, spelling it correct. So the kit 5 is correct as told by Kamal. It is red. It's kit 5 for genital ulcer disease, herpetic. And if there is complaint of lower abdominal pain, preferably a female, think about pelvic inflammatory disease. And what is the color of the kit? 6. Pelvic inflammatory disease. Kit is kit 6. The color is yellow, very important, and the drug included here are very good. Yellow, lower abdomen pain, Kamal, very good. Cefixime and metronidazole, also doxycycline. Ashley Simon, correct. This is with kit 6, and if there is complaint of inguinal bubo, kit 7, and what is the color? Very good, correct, black. Kit 7, black, going to include have drugs as doxycycline and azithromycin. Very important, friends. The color coded kits, STD color coded kits are very important. Kit 1, gray, urethral, anorectal, cervical discharge. Kit 2, green, vaginal discharge. Kit 3, white, genital ulcer, non-herpetic. Kit 4, genital ulcer, non-herpetic, but the patient is allergic to penicillin. Kit 5, red, genital ulcer disease, herpetic. Kit 6, yellow, lower abdominal pain, pelvic inflammatory disease. Kit 7, black, inguinal bubo. This is with the color coded STD kits. Next, we go for some autoimmune antibodies has been asked in the exam. Autoantibodies in autoimmune diseases. Autoantibody. And the associated disease. anti-cardiolipin, and lupus anticoagulant is for SLE and also for the antiphospholipid antibody syndrome or the APLA syndrome. Anti-dsDNA, anti-Smith, SLE, anti-histone is associated with which disease is my question, has been asked in the exam previously. Anti-histone antibody is seen with anti-U1RNP, seen with mixed connective tissue disease. Rheumatoid factor or anti-TCP is seen with rheumatoid arthritis. Yes, anti-histone is seen in. Very good, Ashley Simon. Drug-induced SLE. Very good, correct. Anti-Rho, anti-La is seen in which syndrome? Anti-Rho or anti-SSA, anti-La or anti-SSB, seen with Sjogren syndrome. Very good, correct. Habib Bilal. Sjogren syndrome. Anti-Rho La is seen in Sjogren's. Anti-SCL70 or the anti-DNA. Correct, Ashley Simon. Sjogren syndrome, anti-Rho La, anti-SCL70 or anti-DNA topoisomerase, seen in diffuse scleroderma. Anti-centromere, seen with the Crus syndrome. Anti-SRP, anti-MI2, anti-Jo1 are seen with polymyositis and in dermatositis. What is the name of the rash that is seen in dermatomyositis? Dermatology has been asked in the exam. Priyanka. Church-Strauss syndrome. Very good, Habib Bilal. Is the heliotrope rash. Correct answer, Habib Bilal. Very good. Heliotrope rash is seen with dermatomyositis. Sianka. vagus, granulomatosis, this is with antibodies. Next, we'll go for some specific mosquito vectors and the viruses they transmit. Correct, Habib Bilal. Strawberry gingivitis is seen, correct. Okay, strawberry vagina is seen in. Yes. Answer fastly. Specific mosquito vectors and the viruses they transmit. Disease. Correct. Very good, Habib Bilal. Trichomoniasis. Disease and the mosquito vector. They can ask this also. It remains very important. Can be simple now, but we can get confused during the exam. Please remember this. Think once, twice in the exam. Please just don't take just a second for answering a question and moving on to the next question. You have 1 minute for each and every question. Please think, rethink, then answer the question. Don't get confused. The examiner wants you to get confused, but you should not be like that. Don't get confused. Chikungunya is caused by Aedes aegypti. West Nile fever is caused by Culex. Japanese encephalitis is caused by again Culex. Dengue is caused by which mosquito? Yellow fever is caused by again Aedes aegypti. Dengue is caused by Zika is again caused by Aedes aegypti. Yes, dengue caused by correct Aedes Ashley Simon. Aedes aegypti. Next, we'll move on to some drug regulatory schedules has been asked in the exam. Drug regulatory schedules. Very important one. Schedule H. Yes, Schedule H is the most important schedule out of all. Schedule H. What is the importance of Schedule H? Very important, has been asked in the exam. Schedule H. Schedule C is for biological and other very special products. For example, insulin. They can give you just the name of insulin, and they can ask you which schedule does it belong. Yes, schedule H, very important, friends. Schedule H is for prescription drugs. You would have seen in many medicines, they would have printed in the back of the tablet, should be prescribed only by the registered medical practitioner. This is Schedule H. So Schedule C is insulin. Schedule F for blood and blood products. Just you have to mug up this schedules. Schedule G is with the label of caution and dangerous. And to use only under medical supervision. Next we have Schedule J is for list of diseases that drug may not prevent or cure. Example, HIV. Schedule J. Schedule P is regulations regarding the life period and storage of various drugs. Schedule W is also important. It's drugs that are marked under generic names. So these are some important schedules. Please remember, Schedule H is very important. It has been asked in the previous exam. Next, we move on to some food adulteration disease, and this also has been asked in the exam. SPM part. Food. What is the adulterant? what is the toxin, and what is the disease that it causes. Food. Dal, adulterant added is kesari dal, or also called as Lathyrus sativus. Toxin is boa. Disease caused is Lathyrism. Oil, adulterant is Orgimone mexicana oil. This has been asked in the previous exam. Very important. Orgimone mexicana or Orgimone oil. They have asked what is the toxin present in Orgimone mexicana. They had asked this question in the previous FMGE, and the toxin is sanguinarine. The disease caused is epidemic dropsy. They can give you a image based question also in Orgimone mexicana adulterant usage or in epidemic dropsy disease. Epidemic dropsy. So dropsy, water levels in the body is going to be get increased. There's going to be edema. There's going to be glaucoma, edema of bilateral upper limb, lower limb. They can give you the image of a bilateral upper limb or a lower limb edema, and they can give you a patient is currently using anti-glaucoma agents, drugs, and please list out the toxin. They can ask you, or list out the adulterant. They can ask you. So the answer is Orgimone mexicana sanguinarine. So please remember, very important, toxin mexicana, Orgimone mexicana, and the food adulterant millet adulterant is Protolaria seeds or Junia, and the toxin is Pyrolysidin. Is hepatotoxic, and the disease caused is ascites, endemic ascites. Very important. Food adulterant SPM. Next, we'll move on to some named granulomas. And it is seen in non-caseating granuloma are seen in Crohn's disease, in leprosy, sarcoidosis, caseating granuloma are seen in tuberculosis, histoplasmosis, syphilis, Foreign body granuloma is seen in silicosis and in berylliosis. Stellate granuloma is seen in which disease? And this question has been asked in the previous FMG exam. Dux granuloma is seen in cerebral malaria. This can be a possible question. Dux granuloma is seen in cerebral malaria. Yes, anyone? Stellate granuloma is caused by Bartonella Hensley cat scratch disease. Important. They have asked this question in the previous FMG examination. This is with the granulomas. And we'll move on to some important giant cells that are seen. Langhans giant cells are seen in TB granuloma. As we discussed previously, someone had told green Sternberg cells seen in Hodgkin's. Aschoff giant cells are seen in Aschoff, Hodgkin's lymphoma. Where is the seen? Ewing sarcoma, blasting human, I don't know. Reed Sternbergs are seen in cells are seen in Hodgkin's lymphoma. Aschoff giant cells are seen in, is my question. Totten giant cells are seen in juvenile Ashley Simon RH. I don't understand what is RH. I think you are correct, but please abbreviate. Wharton Finkelday giant cells are seen in measles. Aschoff giant cells are seen in rheumatic fever, and this has been asked in the correct Ashley Simon. This has been asked in the previous FMG examination. Aschoff giant cells, rheumatic fever. We'll move on to some homologous structures in male and female genitalia. This has been asked in the exam. Embryonal structure, what is the homologous for males, and for females, genital ridge, homologous for testis in males and ovary in females. Primordial germ cells, spermatozoa for males, ova in females. The labio-scrotal swelling is analogous for scrotum in males. And what is it analogous for females? Yes, anyone? Urogenital folds is homologous for the ventral aspect of the penis. It is the penile urethra, and for females it is labia minora. Plastic human, I'm not sure whether you will get the PDF, but this class will be uploaded in the YouTube again, and you can watch it again. Labia minora, labioscrotal swelling, scrotum for males, and for females it is labia majora. Genital tubercle, glans penis for males and clitoris for females. Urogenital sinus, prostate gland for males and urethral paraurethral gland, Skene's gland, in females. The sex cords, homologous for seminiferous tubules, Sertoli cells. Yes, blasting human, correct. Blast labia majora. Sex cords is identical, homologous for granulosa cells in females. Gubernaculum is for gubernaculum testis, and round ligament for females. Mesonephric tubules gives rise to efferent ductules and paradidymus of testis. For female, oophoron, oophoron, vestigial part, Next to mesonephric tubules, we have mesonephric duct, also called as the Wolffian duct. In males, it gives rise to the epididymis of testis, ductus deferens, and the ejaculatory duct. And for female, give rise to Partner's duct. And the last one, paramesonephric duct or the Mullerian duct, gives rise to the prostatic atricle and the appendix of testis. And for females, it gives rise to uterus, gives rise to fallopian tube, gives rise to cervix, and the upper vaginal wall. Very important. Homologous structures. This is homologous structures. Next, we'll move on to very important one. They have asked question in this topic. Sites of deposit in glomerular diseases. Very important. They can just ask you give you the nephritis, and they can ask you what deposit is in subepithelial, intramembranous, or subendothelial, or mesangial. They can ask you. So, site of deposit, subepithelial deposit are seen in membranous, nephropathy, and in PSGN. And this has been asked in the previous FMGE exam. Intramembranous is seen with dense deposit disease, also called as the membranoproliferative glomerular nephritis type 2. Subendothelial deposits are seen in MPGN type 1 and also in the nephritis because of SLE, the lupus nephritis class 3 and 4. And this is very important. Possible question can be asked. Lupus nephritis involves sediments of deposits of which site of the nephron? Subendothelial. Then we have mesangial deposits seen with IgA nephropathy. In Henoch-Nolan purpura. Can anyone tell me which is the most common area for developing purpura in HSP, Henoch Snowden purpura? Can anyone tell me what is the site of HSP? It involves mainly the buttock. This has been asked in FMGE exam. RPGN in lupus nephritis class 1 and 2. This is mesangial deposits, and there is no deposits in case of minimal change disease, in FSGS, and in Alport syndrome. FSGS is focal segmental glomerulosclerosis. This is about the deposits. Next, we will go for some teratogenic drugs. This has been asked in the exam. I am discussing only very important topics, very important areas that are being asked previously in the FMG exam. I'm covering those only. So students who are revising can watch this video again when you are eating or when you're doing or relaxing. You can watch this video. Just you guys must be tired reading the books daily, and you might be anxious. So just to relax yourself, you can watch this video. Teratogenic drugs and the birth defects. Drugs. Adverse effects. Lithium causes Epstein's anomaly. Vitamin A or the isotretinoin causes heart disease, facial ear anomalies, quinine can cause abortion, deafness, thrombocytopenia, topiramate anti-epileptic drug can cause cleft lip, sodium valproate, very important, spina bifida. Can anyone tell me what is the vitamin that is deficient in spina bifida? limb defects, palpitation of aorta, yes, vitamin deficiency causing spina bifida. This has been asked in the previous exam. Vitamin D causes supravalvular aortic stenosis. Warfarin causes hypoplasia or hypoplastic nasal structures. Phenytoin can cause VSD, ASD, palpitation of aorta. Yes, the vitamin deficiency causing spina bifida is going to be vitamin B9. ACE inhibitors and ARBs, telmisartan or captopril, enalapril, they are going to cause hypoplasia of organs, renal failure, carbimazole, methimazole is going to cause spinal atresia as a teratogenic side effect. Aplasia cutis, brachioesophageal fistula, or fetal goiter. This is about the teratogenic side effects of different drugs, and the Epstein's anomaly has been asked in the previous exam. Look at some important named triads. Cushing's triad. There is going to be hypertension, bradycardia with an irregular respiration, and the cause for Cushing's triad is going to be intracranial hypertension or the intracranial pressure getting increased. This is the cause for Cushing triad. There's going to be hypertension, bradycardia, and irregular respiration. We have Borchards triad seen with gastric volvulus, and the components include epigastric pain, inability to vomit, and inability to pass a NG tube, inability to pass a nasogastric tube. We have Hutchison's triad, very important. Hutchison triad is seen in congenital syphilis, and the components include Hutchison's teeth, and the teeth is going to look as like a notched. Mainly the upper incisors will be involved. Hutchison's teeth with interstitial keratitis with 8th cranial nerve deafness. Hutchison's triad. Wriggler's triad, they have asked this triad in exam. Wriggler's triad is seen in gallstone, ileus, and the components are small bowel, obstruction, pneumobilia or a gas in gallbladder, and an ectopic gallstone that has moved away from the gallbladder, penetrating through it. Then we have Sainz triad. It is hiatus hernia with gallstones with very important Sainz triad and Wriggler's triad in surgery, very important. They can ask you any one of this Sainz or Wriggler triad, gallstone ileus, small bowel obstruction, pneumobilia with ectopic gallstone, whereas Sainz triad, hiatus hernia, gallstones, and there is colonic diverticulosis. And we have Proteus triad, ENT. Yes, can anyone tell me? Proteus triad is seen in which cancer? Seen with nasopharyngeal carcinoma. The triad components are conductive hearing loss, soft palate palsy, and trigeminal neuralgia. Please note, nasopharyngeal carcinoma is common in Chinese peoples because of the smoked food. So look for keyword Chinese, male or female, with conductive hearing loss, soft palate palsy. It's going to be nasopharyngeal carcinoma, and the treatment is going to be radiotherapy. It responds very well for radiotherapy, and this has been asked again in the exam. We have Whipple striad seen in insulinoma. The components are symptoms of hypoglycemia plus a serum glucose level less than 50 milligram per dl or percentage with a symptomatic relief on glucose ingestion. There's going to be a symptom of hypoglycemia, and when we check the random blood sugar, it's going to be less than 50. And when the patient takes glucose, the symptoms going to relieve suddenly. This is Whipple striad seen in insulinoma, very important. Next, we go for some important radiological signs in OBG. OBG. Vagal sign is seen in tubal ectopic. Ball sign is seen in intrauterine fetal death. There will be X-ray showing a crumpled up spine of the fetus leading to the ball sign. Banana sign is very important, seen in Arnold Chiari malformation and also in spina bifida, which is open and seen. Double residual sac sign is normal USG appearance of a intrauterine gestational sac. Lambda sign is seen in USG of dichorionic pregnancies. Whereas T sign is seen in monochorionic twins. This is seen in lambda sign is seen in dichorionic twin pregnancy, whereas T sign is seen in monochorionic twins. Bunch of grapes sign seen in complete mole. Empty amnion sign is visualization of the amniotic sac and without any concomitant visualization of the embryo, and it is the indicator of pregnancy. failure. So this is with the important radiological signs seen in OBG, obsgyny. Then we'll move on to important physiology factors affecting 2,3 DPG. Increase in 2,3 DPG is seen in case of chronic hypoxia, in anemia. If the person is living in high altitude area, thyroid hormone excess, or the thyroid hormone is going to increase the 2,3 DPG value. Growth hormone, androgens are all going to increase the 2,3 DPG levels. And also important, exercise is going to very important. Exercise is going to increase the levels of 2,3 DPG. Else decrease in 2,3 DPG is seen in case of stored blood and in acidosis. This is factors affecting 2,3 TPG. Then in radiology, they can give you appearance, give you a MRI, and they can ask you whether it is T1 weighted or T2 weighted. So structure, T1 image, T2 image, the gray matter will appear darker in T1, lighter in T2. White matter appears lighter in T1 and darker in T2. CSF dark in T1, bright in T2. Fat going to appear white in color, less white in T2. Air will appear dark in both T1 and T2. This is important in radiology, T1 and T2. So we have some few culture media, very important topic. Culture medium, they can ask question, maybe a sure short question in culture. So the organism, Staph aureus, we have mannitol, salt, agar, lamps, medium, Neisseria, meningitidis, we have Air Morton medium, have Cornybacterium, potassium tellurite agar, Kinsdale medium is for Cornybacterium, Bacillus anthrax, we have the Plet medium, Bacillus cereus, MYPA and PEMBA agar, Vibrio TCBS, Pseudomonas, we have the important citrimide agar, Pseudomalai, Ashdown medium, H influenza, Fildes agar, and Leventhal medium, Brucella castaneda medium. This has been asked in the exam. Legionella, that's previous exam, they have asked Legionella, BCYE medium, Campylobacter, Skidros medium, Heptospira EMJH medium, this is with the important culture medias. And here I conclude today's session. Thank you everyone for listening, for your patience. I wish all the very best for everyone. Thank you.